prestigious oration in the name of Professor V. Seshaya. So to deliver this oration, we have Dr. Sunil Gupta from Nagpur here with us. So to chair this oration, we request Professor N. Rajendran sir and Professor Dr. D. Shantaram sir to come to the dais. We request Dr. Panniselvam sir to read the citation.
Honoring Dr. Sunil Gupta, Diabetes Association of India Southern Chapter, with a great pride and deep admiration, confers the Professor V. Seshaya oration upon Dr. Sunil Gupta, an eminent diabetologist, visionary, academician, and tireless advocate for diabetes care and education. Dr. Sunil Gupta, MD General Medicine, FSc USA, FRCP London, Glasgow, and Edinburgh, FACP, FICP, FIAMS, FIACM, FDI, and RSSDI. He is the CEO and Managing Director of Sunil Gupta's Diabetes Care and Research Center Private Limited, Nagpur. His illustrious career, spanning over 3 decades, is marked by leadership, innovation, academic excellence, and an unwavering commitment to improving the lives of people with diabetes. He has served the profession in key national roles, including National President of Diabetes in Pregnancy Study Group of India, DIPSI 2122, and National Treasurer of RSSDA Headquarters 2019 and 22. Widely recognized for his academic and professional achievements, Dr. Gupta has delivered 26 orations, 22 national, 4 presidential, and 6 international keynote addresses, 7 fellowships, and received 43 prestigious awards from academic and social organizations. He is the only diabetologist from India honored with Outstanding Young Person of World of Award, USA, and his name figures in Guinness World Record 2013 and Limca Book of Records 2016. A prolific researcher and educator, Dr. Sunil Gupta has authored more than 236 publications, book chapters, and abstracts, and has presented widely at national and international forums. His passion for knowledge dissemination is reflected in 3,279 academic programs. 3,279 academic program he has conducted over 31 years, an extraordinary contribution averaging more than 2 programs per week. His excellence in research has been recognized with a 6 consecutive Best National Research Paper Award by RSSDI. Currently serving as Executive Editor of Indian Diabetes Educator Journal, RSSDI, and Associate Editor for 2 reputed journals, Dr. Gupta has also contributed as Principal Investigator in more than 25 landmark clinical trials, shaping diabetes management strategy in India. His numerous recognitions include Outstanding Community Service Award by IDF President Dr. Andrew Bolton, 2021, Madhumeha Ratna Award 2022, Excellence in Healthcare Award 2025, National Foxy Dr. D.C. Datta Award 2025, and the distinction of being the most versatile diabetologist of the country 2022. In recognition of his remarkable academic journey, his pioneering leadership in diabetes education and research, and his tireless dedication to advancing diabetes care in India, Diabetic Association of India Southern Chapter is privileged to honor Dr. Sunil Gupta with the Professor Dr. Seshaya's oration with profound respect, sincere gratitude, and warm congratulations. Thank you.
Professor Shantaram sir will honor the orator with a shield. Professor N.R. sir will honor the orator with a shawl and a medal.
So nice, so nice. Thank you very much, sir. Thank you. Sir, yeah. I'll hold it.
Good afternoon, everybody. This session is unique in many ways. The first is our Guru and father of GDM in India, and our senior Professor Sundaram They are sitting down, and both of us, the chairperson, myself and Shantaram, we are the first batch of diploma in diabetology at Madras Medical College. We are terribly privileged to chair this particular session, especially you are the speaker. You know very well about the quantum of the interest our Guru has got in this field. See, he used to say, however trivial, and hyperglycemia is teratogenic. That is the first word and that is the first line in his projections whenever he says. So that amount of the tight control he wants and we want to be at the entire 24 hours during the pregnancy. Of course, there are many ways of attaining that value. I think you are going to tell that in detail in your oration speech. And I may request my co-chairman also to say a few words.
Good afternoon to my teachers, colleagues, and the budding specialists. It's really an honor to share Rosesha's oration with Dr. Sunil Gupta as the speaker. We all know that we are treading into a specialty, this hyperglycemia in pregnancy. If only the hypothesis of our mentor, Rosacea, prevention of GDM comes true, it will change the landscape of the epidemiology of type diabetes in India. And this concept, Indian solution needs Indian problem, is also so true because you know the nature is endowed with genetic and ethnic variations, and what is applicable to the West may not be applicable to our population. And since most of the evidence what we have is today imported from the West. Now let us listen to Dr. Sunil Gupta's oration and understand what is the Indian answer to the hyperglycemia and pregnancy. Over to you.
Thank you very much, Chairperson, Dr. Rajendra sir, and Dr. Shantaram sir. Thank you very much for chairing this session. I'm really feeling honored, and of course, in presence of my own mentor. I always call him as my eldest family member of my Nagpur family, and that's why it's not only a member but the extended family member of our family, Dr. Seshaya sir, and equally same for Dr. Sundaram sir, who comes all the way every time to Nagpur for me for conducting a insulin workshop. Sir, thank you very much for being with us, and I'm really feeling honored for this. My today's talk is on insulin therapy in hyperglycemic pregnancy, initiation and up titration in Indian perspective. And let me share with you whatever data I have up till now on insulin therapy in HIP is very rarely seen across the globe, and this is possibly the only data coming from India, which possibly will dictate most of the Asian population about insulin initiation, how should we go ahead. Of course, my humble thanks to Dr. Professor Seshaya for this honor, and of course Dr. Anand Moses, Dr. Shanamongam, Dr. Rajendran, Dr. Bhavatarani, Periyandavar, Dr. Dharmarajan, Dr. Paneerselvam, every one of you, thank you very much for being with us always. There's no conflict of interest for this particular session. And these are two important medals. This Padma Shri medal and one of the topmost medal in Army, which Professor Seshaya, Padma Shri Professor Dr. V. Seshaya has got. And we really feel honored that the whole diabetology family is feeling so much as if they themselves have got the medal. And they have been honored for. So, sir, thank you very much. And compliments from all of us. And this is the rarest of rare picture, which you are receiving the Padma Shri honor from the President of India. My talk will have some introduction, one or two cases of GDM or PGDM, and then we'll have insulin therapy in overall recommendation, and we'll see. My journeys of pregnancy diabetes started not from Professor Seshaya, but from Sam G.P. Moses, sir. And why so? Because I was very, very vocal to most of the senior people because of my registration number in RSD is 207. So practically I worked with all founders of RSSD at those days. I was very close to Professor Sam G.P. Moses, and I used to talk to him, sir, what next I should do, what next I should do. And he told me one day, Sunil, you should now join some specialty in diabetes. I said, which one I should join? He took my hand and took to Dr. Seshaya sir was sitting in that RSSDI meeting. He used to have only 70, 80, 100 people those days in the meetings, not more than 150. He took me and he introduced myself to Professor Seshaya. So my always regards to Professor Sam G.P. Moses, who has not only inculcated the seed of pregnancy diabetes those days, and then it made me introduced to Dr. Seshaya. And since then, I became a family member of the Seshaya family, Chennai family, Tamil Nadu family, and you can witness it even today here. Of course, then Dr. V.S. Asgaonkar was one person from Mumbai who has taught me diabetology in Mumbai. And then, of course, Dr. Seshaya, as I told you. And these are very early days, 2008. So almost 17, 18 years from now that we have taken DIPSI in Nagpur. And that was the first time DIPSI has come out of Chennai. From Tamil Nadu, it has been shifted to Nagpur for the first time those days. And sir also has some reluctance those days whether it will be done well or not. But somehow, sir, we could do our job on those days in 2008. And these are some of the pictures which I could capture from sir, and I feel they will be becoming a unique pictures of its time and those days. And then we also have some pictures. This is with Prime Minister of India. And then this is Dr. B.C. Rai Award. And these all pictures I could get with the help of Dr. Bhabatarani and Dr. Shanmungam. We all went to their place and sir's place, and we took those pictures. And this is with madam. And I was asking yesterday, we were sitting with sir and said, Sunil, I have never seen madam before marriage. So my father went and fixed up everything. And madam said, he directly came for the marriage just one day before the marriage. So these are the stories in those days. My father also have the same story, and most of you will have the same stories. But yeah, and of course, Dr. Sam G.P. Moses, those days. And this is another picture which I'll show you somewhere here. Yeah, it is here. This is 1999. So almost 26 years from now, when he came to Nagpur by train from Chennai, it was almost 20 hours train from Nagpur to Chennai those days. There was no flight, overnight journey, 20 hours journey. He came by train to Nagpur just to deliver an oration, Dr. P.K. Sen Gupta oration, 26 years ago. And you can see it still looks the same. I have lost mustache, not lost, but I've removed rather. So, but these are those pictures. You can see his smile, even this particular photograph. And this is the DIPSI in 2008, February. And these are, you can see a lot of changes, metamorphosis in me, but as well as Kavita madam, but sir still remains the same what he was in 2008, and this is 2022, again in Nagpur with my family, and this is 2025, and I went and received again a personal copy of the book he wrote, and this is the blessings I'm taking from him. And of course, Dr. Jitendra Singh was one of the part of, he was the joint secretary of DIPSI, those who are not aware, those days. And we were sharing the same post, 2 joint secretary in RSSDI, and he was one of them. And then he gave the award last year on Prega Talk, our public awareness program, which I'm going to cover in the lecture. So let me come to the topic proper about the recent classification of hyperglycemia and pregnancy. So it's a now umbrella term. And you have one pure GDM, which usually appears in the 2nd or the 3rd trimester, more commonly after 24 weeks of pregnancy. When it comes to a global definition, we traditionally say after 20 weeks of pregnancy, which will be possibly pure GDM 140 to 199 after the GCT. But DIP category will be pre-existing type 1 or type 2, or those who are diagnosed for the first time during pregnancy, commonly type 2, rarely type 1. I have seen out of maybe 2,500 pregnancies, which I must have seen in my clinical practice, type 1 diagnosed during pregnancy was only one case. But most of them will be either IGT or pre-diabetes or type 2 diabetes, but they will be also treated with insulin, because most of these pre-diabetes or pre-gestational diabetes, we used to call them, will need insulin therapy to achieve the glycemic targets. Of course, these are the oral drugs, which is not the topic of discussion today. Metformin, glibenclamide is not being used by us. glabin, but metformin is regularly being used, and the non-pharmacological lifestyle modification. Insulin remains the first drug of choice across the globe, as well as DIPSI also recommends that, and Government of India also recommend. What about the glycemic targets? So to achieve these targets, these are the updated guideline 2023 from DIPSI. And these guidelines now have lower cutoffs also. So 80 to 90 is more acceptable. But if you go through the CGM, the cutoff is 63 to 140. So 80 to 90 or should not be above 90 fasting. 2 hours should be between 120 to 120, but we can accept up to 90 to 120. And mean should be 95 to 105. Mean should not exceed 105. And the baby weight should be between 2.5 to 3.5. And these are the CGM metrics, where your cutoff is 63 to 140. For pregnancy, the recommendation is those who are GDM and those who are type 2 diabetic pregnancies, they should try to achieve 90% of the TIR between 63 to 140, while those who are type 1 diabetes, you can accept 70% because of increased risk of hypoglycemia. Now, this slide again we have procured long back from Sir, is still valid here. So these are some of the glucose, amino acid, ketones, triglycerides, they all pass through the placenta passively, but insulin doesn't cross the placenta, and that is why while teaching, while educating people with women with diabetes in their family, we always say insulin doesn't cross the placenta, and that is why it is one of the first drug of choice in pregnancy diabetes. So insulin and HIP, these are some absolute indication: high HbA1c, ketonuria, so renal dysfunction, hepatic dysfunction, significant morbidity, obstetric morbidity, macrosomia, IUGR, hydramnias, deteriorating glycemic control, corticosteroids. 50%, now remember this, 50% of the women who are on metformin will ultimately need insulin supplement as an addition drug to achieve the glycemic control of 90 and 120 in most of the pregnancies. 50% will do so. Out of 10, 5 will need additional insulin therapy in the follow-up in GDM women. So all women with type 1 diabetes, most women with type 2 diabetes, and 20 to 30% of GDM women will need insulin therapy. Now, which insulin is being approved in pregnancy diabetes? So instead of reading this thick slide, I have kept just one statement here: except glulysin. All insulin other than other insulins are approved in HIP. There is one little warning about glargine. Those women who are type 1 or type 2 already on glargine got conceived, and we as a clinician feel that by withdrawing glargine might deteriorate the glycemic control of a woman. In that situation, you can certainly continue glargine also. Of course, degludec has been approved as a drug for pregnancy. You have just seen it in Sriniva's presentation. So glulysin is the only drug which has not been tested. Insulin, now we have some good data available from our center, as well as some data from multicentric study. So I'll just share with you. This is one case of LADA type 1 diabetes. So this case, basically a lady, 28-year, housewife, vegetarian from a city of Satna from Madhya Pradesh, and she has 28, she had first pregnancy at 28 weeks. She became COVID positive. She had moderate ketosis, managed locally in 2020, and but unfortunately record is not available, but she ultimately has lost the baby. She has IUD at 28 weeks. Her fasting C-peptide done 2 weeks after the IUD, and which was showing low 0.9. That means that possibly she was a known case of diabetes, but she was missed out, and as a case of LADA, the C-peptide was low. GAT65 was not done that time, and she might be having LADA, and that's why she did not land up into frank ketosis. But at the time of 20 weeks with COVID, she had ketosis. So she was a case of LADA possibly. And she again came to Nagpur after all this. That time, at the time of IUD, her HbA1c was 12, pre-conception in August, it was 12.9. So she got conceived with very high blood glucose in between COVID and all and ketosis. Once you have ketosis, the mortality rate in the baby is, neonatal mortality is almost 50%. And we have witnessed it. I have got up till now 2 cases of ketosis in pregnancy. One I lost, one I could save. Now, this lady came to us in 2021, and we have evaluated her, and we put her on the pre-basal bolus therapy, and we brought her HbA1c to 6.07. This is pre-conception counseling. We could get the HbA1c done, and it was 6.07. No other complication, no other vasculopathy. She was on basal bolus therapy. She went back to Madhya Pradesh, and then now you see her, she got conceived there in Madhya Pradesh. Then there was a lockdown and she could not make it, and we all had teleconsultation during that particular period, 21-22. Said she had preconception blood glucose, which was 0.7 unit per kg body. Now, this is a very important slide. Please go through it properly. This will teach you, or will try to learn from this slide, how the trend of insulin goes in type 1 diabetes once they become pregnant. Same we'll have try to learn in type 2 diabetes as well as GDM. So, preconception, her requirement was around 0.78 per kg body weight. As the pregnancy advanced from 10, 22, 32 weeks and 36 weeks, it went up to around 2.08. So almost 2.5 to 3 times increase from the baseline. This is a single case. At 36 weeks after delivery, it was this. Postpartum day 10, it came to almost 50% of the preconception level. And this is very important to know, that your insulin requirement in the postnatal phase goes down to almost 50% of the preconception level. And then after 30 days, it again went back to almost preconception level. And this is the area where your patient should be properly given counseling about the reduction in the insulin doses. And this is a graph. This is how the insulin requirement went up on 36 units. And this is the last period. At around 36 to 37 weeks, there will be a plateau, or there can be little reduction in the insulin doses because of reduced placental hormones. And then after 37 weeks, once you get delivered, or even at 37 weeks, once delivery, it went up to 20 units and then again went up to 54 units. More important than that is, we have done post-breakfast, post-lunch, and post-dinner blood glucose regularly in these patients. And what we found is, pre-breakfast dose was lowest, pre-lunch was little higher, and pre-dinner was highest. That means the pre-dinner dose, which very less number of people they actually monitor, is at most important, because if you see some cases where you are unable to achieve a good HbA1c control, or if you see some problem in the fetal growth, or some other issues you can commonly see hydramnias, polyhydramnia, and you say fasting is normal, post-breakfast normal, still why it is going up? Possibly the post-dinner blood glucose has been missed out. So if you see this is the breakfast, lunch and dinner, and if you see the dinner dose is supposed to be the highest here, and the basal insulin also less. It is not what is written in the books that 30%, 70%, 50%, 50%, short-acting, long-acting, nothing works in pregnancy. You have to individualize the doses. Ultimately she delivered with Caesar at 36 weeks, required intrapartum insulin infusion during pregnancy. She delivered a baby. She has earlier IUD. Before that, she had one abortion. Now she delivered a normal baby with Caesar, nothing else, no congenital malformation, no complication, everything went very well. Intrapartum blood glucose should be kept between 70 to 120. If it is higher, then there are high chances of having neonatal hypoglycemia. Then what we did is, we realized that there are multiple such cases, so we have come out with the data of 33 type 1 diabetes pregnancy, and recently in IDF we have presented it in Bangkok. And this 33 pregnancy, we have seen this out of 2,746 total patients with hyperglycemia pregnancy, around 90% were GDM, 10% were type 2, and 1.4% were type 1. And this is exactly what is written in the textbooks is being seen here, Indian population. Mean weight was normal, mean BMI was normal, mean age was 27 years, and requirement preconception, again, 0.85 units. At the time of diagnosis, around 1 unit, and then in the second trimester, 1.1, went up to almost 1.2 units. So again, 0.85 to 1.2 units. and postnatal came down to again almost 50% or 60% of the baseline, and postnatal after 30 days, 0.78 units. So again, in the 33 pregnancies with type 1, the same pattern has been seen. What about type 2 diabetes women? At the time of first trimester, there is data of around 100 pregnancies, which again got published. 0.5 unit per kg body weight, third trimester, 0.8 unit per kg body weight. Now, this is not being tested across, and if you get these ideas, you can certainly implement these principles of insulin therapy in pregnancy in various patients. Then we have seen why you have the highest post-dinner, pre-dinner requirement of short-acting insulin. So what we have seen is the calorie intake in breakfast, lunch, and dinner, the dinner was found to be the highest. This is the first trimester, and this is the third trimester. The dinner calorie intake was highest, and that is why they are requiring short-acting insulin or rapid-acting insulin from the central India population, more common versus pre-breakfast doses. And this is the calorie intake chart, 270, 427, almost 463, which was statistically significant when it was compared with breakfast and the supper calories intake. Then we have seen one paper has come, and this paper is here. This paper has come from US. Type 1 diabetes twin pregnancies, they require double the dose of insulin versus singleton pregnancy. I thought, I discussed with sir also that time, before going through, I thought, sir, this paper has come, but we have seen few of the twin pregnancies, and I did not observe this. He said, Sunil, I told you, Indians, we have to see Indian patient, we have to give Indian solutions to people. So why don't you do some study in this? So I took out some of the patients of mine, and we also requested this Dr. Gupte from Pune, and 2 centers patients. We had around, I feel, 44 or 44 patients in the 2 centers. 30 and some around 28, 30, 40, 44 patients. And we have come out with a wonderful statement. You can quote this particular study. GDM women with twin or singleton gestation differed insignificantly in their treatment strategies. This is about GDM. That was a type 1 diabetes and insulin doses. Insulin requirement need not be proportional to the number of fetuses in GDM women, and treatment should be planned to achieve the glycemic goal even in twin pregnancy rather than giving the number of, suppose someone is triplet, does not mean that she will require, instead of 60 units, she will require 180 units of insulin. Should not do that. We have another case here, which is again a very close to my heart as well as sir's heart, about someone who has GGI, gestational glucose intolerance. You give glucose, 75 gram glucose, irrespective of the time of the meal, take 2-hour test. Instead of crossing 140 and it is not GDM, but it has certainly crossed your cutoff of 120. So 120 to 140 is a borderline case. So we call it a gestational glucose intolerance by DIPSI, but other population or other countries, they call it as IGT in pregnancy. They also call it as isolated abnormality of blood glucose. Some of them, they call it as mild GDM. You can see multiple papers and meta-analysis now on mild GDM. So these mild GDM again need to be taken care of. This gestational glucose intolerance of 130 here. And this is a classification we gave it from DIPSI in 2006. And then we have come out with data, those women who had fetal losses. So we have done just an observational data. Those who have more than one or more than one fetal losses because of some reason in the past, what we have seen is that fetal loss has come down from almost 36% to less than 4% once you start them on the proper therapy. And many of them, they required even insulin. Small doses of insulin may be required in these patients, and you can save these babies as well as console these mothers also. Now, this paper is on GDM. We did not have a good data comparing the 2 population. Very important, please listen to this carefully. We had around 400 pregnancies of GDM, 400 pregnancy who had been put on diet therapy from the beginning. Until end, they required only diet therapy, no supportive pharmacotherapy or insulin therapy, only on diet, medical nutrition therapy. Another population was given insulin from the beginning of course, the basic principle of 2 weeks therapy of medical nutrition therapy, but required insulin therapy and ended it with insulin therapy. So we wanted to understand what are the parameters which will dictate that this woman is likely to need insulin, another woman is likely to need only diet therapy. So we had tried to do this statistical exercise by doing propensity match scoring system. And this again one of its own kind in the world. Women receiving insulin had low risk of preterm, low birth weight, and macrosomia. Such an important thing. Insulin company should also now highlight this. Women receiving insulin had low risk of preterm, low birth weight, and macrosomia. Neonatal hypoglycemia was more common in insulin-treated group because they were more severe hyperglycemic. They required pharmacotherapy. 2-hour post-glucose value, important, of more than 162.5 or fasting blood glucose more than 90, above which the insulin is likely to be required. So someone here doing GCT, more than 162.5 might need insulin therapy. Of course, it has to be highly individualized, but there are some more risk factor. Of course, there's a propensity score matching was done, and also it has been shown which women will require higher insulin and which women will require lesser insulin doses. So I'll just go through the charts here. So this is about the two groups. Now there are 386 here and 427 here, and they have been matched here. This is an unadjusted group, and if you see bad obstetric history risk factor, family history, and pre-pregnancy BMI higher. If you have 3 major risk factors and of course higher age, they will require insulin therapy more commonly versus those who don't have these 4 risk factors. And one more thing here is, if you have fasting blood glucose is higher, post-glucose is higher, and HbA1c is higher, again you require higher dose of, may require insulin therapy. Neonatal hypoglycemia was more common in this group who were on insulin therapy. And then the PIH was also common, more common in the insulin group versus the diet group. Neonatal hypoglycemia, after adjusting the all other covariates, we had the group of then 386 in each group instead of 400 here. So now we have 386, both of them have compared by adjusting all the covariates, and we could see neonatal hypoglycemia seems to be consistently higher in the insulin-treated group. The treatment effect for each outcome was obtained after the adjustment of age of the mother, parity, bad obstetric history, family history of diabetes, pre-pregnancy BMI, HbA1c, fasting, and 2-hour post-glucose values. And what are the results? The odds of preterm birth, low birth weight, macrosomia due to insulin were close to 1 and statistically not significant. So we had some notion which was now not very common, but earlier it was said, more tightly you control, more you'll end up into IUGR, which was not seen here. There's less risk of macrosomia, but after adjustment, it has come non-significant. Neonatal hypoglycemia is 4.5 times higher in this group versus the diet group. LGA, risk of LGA compared to was lower in the insulin-treated group. So large for gestational age was lower in the group. Risk of IUD was also lower in the insulin-treated group, and risk of PIH was higher. So PIH and neonatal hypoglycemia was higher. Other LGA and IUD was lower in the insulin-treated group. Then we said initial and the full-term insulin doses have been seen. Initial insulin doses and the insulin doses at the time of delivery. And we have tried to compare first to the third quartile. So we have actually divided this total 387 have been divided into 4 different groups, almost 90 each. And what we have seen, and then we have done one exercise called as love plot. It's called a love plot, LOVE, love plot. And love plotting has been done, that's again to adjust the covariates and to see how overlap it is. So if you see first, second, and the third quartile, almost 98, 95, 94 patients have almost similar insulin doses. 9, 10 units at the baseline, and 18, 19, 20, 17 units at the time of delivery. But the fourth group who have the risk factors, their risk factors again is age, parity, bad obstetric history, positive family history, pre-pregnancy BMI, HbA1c, fasting, and 2-hour. This group, if they have these risk factors, they not only require, higher patient require insulin therapy, but also require higher doses of insulin versus other GDM women who don't have these risk factors. So this is again another way of telling the 2-hour value. Again, I told you 162.5 and the 90 milligram fasting is again correlated. And this is the fourth quartile which required insulin therapy more higher insulin doses. So this is the chart which you can just quote somewhere, or you can take a picture if you want. Those gestational glucose intolerance, if requiring insulin at the baseline, they will require 0.1 unit. At the time of delivery, it will go up to 1.15. GDM 0.25 to 0.4. Pre-GDM type 2, 0.5, then 0.8. And type 1 diabetes, which I presented this year itself in IDF, 0.85. And at the time of delivery, it will be 1.2. But at the end, insulin doses have to be individualized. This rule will be just guiding you. So long-term outlook of the offspring of diabetic mother, if the glycemic control can be maximized to the extent that fetus no longer recognizes that the mother has diabetes, then the treatment of mother during pregnancy may become the first step in the prevention of obesity and diabetes in the offspring. And that's what Sir said, the fetus should not recognize that the mother has diabetes. So tightly you should control blood glucose. So try to screen them early and treat them early. And this is the World Diabetes, the National GDM Day, 10th of March. India is the only country which has done this, and we should have awareness program across this year, but also in the month of March. And this is a Prega talk, which is being conducted by us from the day of my presidentship in DIPSI. We do 22 languages we have in the Constitution, and we do in all the languages we have done this Prega talk or pregnancy diabetes awareness program across the country. And this is the third cycle going on, and this third cycle has again been, every time we start with Tamil, and this year again we started with Tamil. So GDM is the window of opportunity, and ek chance se bache do jaan, and that's why we should do GCT to each woman coming to you. Focus on the fetus for the future, mantra from Sir, and that we still continue. With this, I stop here. Before I stop, I always show this slide, that instead of cutting the cake or instead of cutting the pastries for any occasion of your anniversary or birthday, instead you cut the fruit and give another message for the public awareness program or public awareness for their. If you want to save the endothelium of your patients, you have to cut down this hydrogenated fat, which is there in most of these fast food or most of these cakes and cookies. So cut the fruit and not the cake to celebrate an occasion. Wish you all a happy Teachers' Day, Onam, Ganesh Festival, and Paryushan which is followed in Jain. Thank you very much for patience listening. Thank you.
Let's all give a standing
Let's all give a standing ovation. That was a very wonderful oration by Dr. Sunil Gupta.
Thank you, Dr. Sunil, for your vibrant talk on the Indian perspectives of insulin treatment in hyperglycemia in pregnancy. In fact, I have told, and by looking at the slides, we have seen your vast experiences, not only in the field, and also our mentor, and also the father of diabetology of India, Professor Sam J.P. Moses. In fact, we both of us have been very happy to look at these slides. Thank you, sir. Thank you once again. On behalf of my co-chair, and who also will talk few lines, and we thank for your beautiful lectures. Thank you, Sunil.
Thank you.
Thank you, Dr. Sunil Gupta, for an excellent lecture on hyperglycemic pregnancy and the use of insulin, the Indian perspective. After your lecture, it's become really debatable whether you are blessed to deliver the oration in the name of Professor Asia, or the oration is blessed to have your talk today. So, okay.
Thank you.
The take-home points, what you learned from your talk is the insulin sensitivity changes in pregnancy, both in type 1 and type 2 diabetics, and the glucose profile is individualized based on the hormonal changes as well as the lifestyle of the patient. And usage of insulin in hyperglycemic pregnancy translates into clinical benefits in reducing the macrosomia, low birth weight, and the premature deliveries. Thank you.
Thank you. Thank you very much, sir. Thank you for your comments. Thank you. Thank you very much.
Since it is in orations, as a customary thing, no questions are allowed. So we will conclude these sessions and move on to the next session.